Hello everyone, welcome back for part 3 of our introduction to pre-hospital pre-oxygenation. My name is Austin Kaiser. I'm a flight paramedic and the clinical educator for PHI in California. Part 3 is stepping away from the actual intubation process and focusing on one of those HOP killers. So we have addressed the first HOP killer, that hypoxemia, during parts 1 and 2, and we're also addressing the pH or the acidemia portion in part 3 of our Introduction to Mechanical Ventilation series. So this is dealing with the hypotensive or the hemodynamic killer that we can have in our intubated patients. So we're going to look at the hemodynamic component of the HOP killers, and we're going to look at the different induction and paralytic medications that we use in pre-hospital medicine. So here's our last patient. We have a 44-year-old female. She comes into the emergency department. She's altered and combative, no known history, family's not present, smells like ETOH, has track marks on her arms. We have all met this patient before. Upon arrival at the emergency department, she becomes really bradypneic and is not managing her secretions at all. Current vitals are as follows. She has a GCS of 6. She's pale, cool, moist, has a blood pressure of 8.4/3.7, has a heart rate of 133, sinus tachyectopy. Respiratory rate is 8 and shallow, sitting at 88% on room air. Her lungs are clear, pupils are pretty sluggish at 4, and her blood sugar is 155. We put her on a cannula, and her sats continue to diminish. She has a respiratory rate of about 6, and the decision is made that we need to intubate this person. So let's talk about what we're going to do, right? So let's walk through our vent card here, or our intubation card. So the first thing we do is we get our initial setup of our BVM, our nasal cannula, PEEP valve, our HME, and our end-tidal CO2. We've got our full setup. We're going to immediately take mass control and run through our protect algorithm. So we're going to position our ear to the sternal notch. We're going to raise the mandible. We're going to insert an OPA or an NPA. We're going to make sure we're doing 2 thumbs down masking. We've got end-tidal CO2 with every breath. We're making sure that we check our O2 and PEEP. So we've got 15 liters per minute on a cannula, 15 liters per minute on a bag valve mask, and we've got our PEEP valve set to 15 centimeters of water pressure. We're going to start optimizing our ventilation. So because she's only breathing 6 times per minute now, or 8 times per minute, and it's shallow, and her end-tidal CO2 is pretty high, up in the 50s, we're going to need to optimize those ventilations by having one of our firefighter partners or EMT or paramedic partner on the ambulance is going to go ahead and start bagging them, making sure that we are not over volumizing our patient. We're going to get a plan for her airway, so that way we are doing some sort of airway assessment, and then we're going to oxygenate for 3 minutes and denitrogenate once we've reached a nice oxygen saturation of 100%. And then we're going to intubate the patient after we communicate our emergency action plan. But is there anything else really troubling about those vital signs? So we see that she's got a GCS of 6, whatever. Her blood pressure is 84/37. I'm not really stoked about that at all. Her heart rate's pretty darn fast as well. And then we are addressing her sats and her respiratory rate. But that blood pressure is just not acceptable, right? So is she going to crash? For those of you that have been standing or staring at that cartoon wondering why I put that on there, that's Crash Bandicoot. And I assume only 2 or 3 people were going to get that reference. So is she going to crash? And probably. And how are we going to stop it? Well, we're going to stop it by addressing her pipe problem, right? So hypotension is the #1 reason for cardiac arrest during the peri-intubation phase, and how are we going to prevent it? So we need to plan ahead. So is this patient currently hypotensive? Well, yes, I think by most people's measures, 84/37 would be pretty hypotensive, but she does still have an okay map. But the biggest thing that we can say is that she has a shock index greater than 0.9, which means that you are going to take your heart rate and divide it by your systolic blood pressure. And if it is greater than 0.9, which for her it's about 1.6, so that's way greater than 0.9, then we have a pretty good idea that she's going to become hypotensive as soon as we give her sedative and her paralytic. So we need to make sure that we are prepared for her to become hypotensive by probably preventing it from happening in the first place with some sort of pressor. So let's talk about picking your poison or looking at your different induction agents. So all induction agents, regardless of really what they advertise, will typically decrease your blood pressure somewhat because they reduce your catecholamine response. That patient who is a shocked patient is dumping every catecholamine that they have in their body into maintaining a good blood pressure. So as soon as you give that induction agent and you reduce that catecholamine response, you blunt that sympathetic tone, you're going to have some sort of vasodilation. So let's talk about which induction agents we should use in order to prevent that big drop in blood pressure. So the first thing we have is Propofol, very common induction agent, very common sedation agent for continued sedation in the hospital. We should never use that for and I don't like to say the word never, but we do not practice using Propofol for our induction agent here at PHI. It is not cardiac neutral at all, and it will make you very hypotensive in a shocked state. Etomidate is something that you may or may not carry on your ship. It is relatively cardiac neutral, but the only problem with etomidate is because it's not this like really fast first pass thing like ketamine is. You may have to increase the dose in a shocked patient. So if your patient does have a pretty good shock index, you may have to actually use a larger dose in order to receive the same level of medication to the brain. So you typically will have at least a small reduction in the blood pressure, typically nothing profound. However, the one that we typically use here at PHI is going to be ketamine, and it's going to be 1 to 2 milligrams per kilogram of their ideal body weight. Remember that this is not dosed based off of their actual body weight. This is dosed based off of their ideal body weight. So 1 to 2 milligrams per kilogram of their ideal body weight, and it's a slow IV push over 120 seconds. So slow IV push over 2 minutes. Some of the really nice things about ketamine is that it has good analgesic effects. So not only is it a dissociative medication, but it also has analgesic effects as well. And if you push it slow over 120 seconds, you actually get a sympathetic surge. So not only do you not have a decrease in your blood pressure, but you may actually see an increase in your blood pressure. For me, the thing that I love about ketamine the absolute most is that while we are doing this RSI procedure, after you give ketamine, you maintain the respiratory drive. So these patients are not going to become apneic like they would if you gave Versed, and oftentimes when you give etomidate, they will have an apneic period as well. With ketamine, you maintain your respiratory drive, which is super imperative for your metabolic acidosis patients like a DKA or an aspirin overdose or what have you. Very, very, very important. The nice thing is, too, is it's a first pass saturation, and so your onset of actions is almost immediate. By the time you're done pushing the medication after 2 minutes, it will have already been in full effect. So paralytics, there's really 2 paralytics of choice. We have succinylcholine and rocuronium. Sux is a very common paralytic we see a lot. It does have a pretty short duration of action. So one of the biggest arguments I see for the use of succinylcholine is that it has a short duration of action, and that what happens if you don't get the airway, this person's going to be paralyzed for a long time if you're using a long-term paralytic, and Sux wears off very quickly. And so if you don't get the airway, then you don't have to worry about it. But what I would have to say, the argument that I would put against that is that if you make the decision to intubate somebody in the field, that person is going to have some sort of definitive airway from us eventually, be it either an endotracheal tube or be it an iGel or be it a surgical airway. If we decide that that person needs an airway intervention, they are going to get an airway intervention from us. And so we don't really need a short-term duration of action like in succinylcholine. It's going to be much more beneficial for us to have that longer 30 to 45 minutes of rocuronium. So we tend to use rocuronium at PHI. The typical dose is going to be 1 milligram per kilogram. Obviously, you always need to check your drug profiles on web manuals in order to see any dosing adjustments on ketamine or on rocuronium or anything else. because it very well could have changed from the time that this video was made. Nice thing about rocuronium, it does have very little side effects other than it can make you hypotensive, and it has a very long duration of action, or it's a moderate duration of action of about 30 to 45 minutes. So if they are going to become hypotensive, we are not going to not give a sedative. We are not going to give a paralytic. We are going to fix their problem by giving them pressors or fluids. So is the patient fluid depleted? Do they need blood? We need to be hanging fluids on these patients if they're hypotensive. But the biggest thing is we need to be starting a pressor, right? A short-term pressor is not going to increase their mortality or their morbidity, but a short amount of hypotension will absolutely increase their mortality. And so acute hypertension is not dangerous, but acute hypotension is fatal. So we need to be making sure that we are starting pressors on these patients that need it. Don't start it after the intubation, start it before the intubation. A typical pressor that you may see in the field would be Levophed or norepinephrine. It has mainly alpha, but a little bit of beta effects, so you may see a small increase in their heart rate, a very small increase in their heart rate, but you'll see a pretty good increase in their blood pressure. It's a very potent alpha agonist, and we do typical starting doses anywhere from 5 to 10 micrograms per minute. You take 4 milligrams and mix it in a 250 milliliter bag. Like I said, always refer to your drug profiles and web manuals in order to see any type of dosing adjustment since this video is made. But Levophed is an incredibly good medication to use for these types of shocked patients because it does have a lot more bang for your buck as far as blood pressure goes and a lot less that effect on your heart rate, like something like dopamine or epinephrine would have. However, it does take some time to get a drip going. You maybe have to run back to your aircraft to grab a medication bag, or you may have to and you're definitely going to have to mix it together and then program it into the pump and start to hang it. And while it does have a very quick onset of action, all of those things take time that you may not have. So one great solution is push-dose epinephrine, which is something that we use over in this program, and I'm sure that most other programs at PHI practice using push-dose epi as well. It's a very potent alpha and beta agonist, and what you're going to do is give a 10 to 20 microgram IV push of epinephrine, and that is going to bridge your patient to the point where they are not going to have this refractory hypotension during the intubation procedure. It can bridge them to a long-term pressor, or if this is somebody that doesn't need a pressor, but they are really on the cusp of becoming hypotensive, or they do have a high shock index, but you're not really thinking that they need a full-blown Levophed drip, a push-dose epi drip to bridge them through that initial intubation and that initial switch to positive pressure can be vital for this patient's survival. So you're going to take a 1 to 10,000, commonly referred to as a code epi. You're going to take a 3-way stopcock, some saline. I have a preloaded syringe pictured in here, but we really need to be using sterile saline instead. And then you're going to take a 10 milliliter empty syringe. You're going to mix 1 milliliter of that 1 to 10,000. So you're going to mix 0.1 milligrams of that 1 to 10,000 into 9 milliliters of saline to give you a total concentration of 0.1 milligrams in 10 milliliters, which gives you a concentration of 10 micrograms per milliliter. So you're going to be giving 1 to 2 milliliter pushes of this epinephrine as needed to blunt any type of hypotension from this intubation procedure. So that was just a quick one, guys, but if you have any questions, feel free to reach out. My email is akaiser@phiaeromedical.com, and I look forward to seeing you guys out in the field.